Okay, this is part 3 of the EKG interpretation series. This will be the shortest video. Really, I want to go over just a few different clinical pearls as far as some special reasoning behind some of the electrolyte evaluations and how EKG findings should be treated in primary care versus referral to acute care settings. This is just summarizing what we've reviewed in part 1 and part 2. Part 1 and part 2, we really just went over interpretation and how to look at an EKG and be able to read it and what all those readings mean. From this point on, we're just going to focus on some clinical pearls and interventions that may happen for certain arrhythmias that you see in practice. First, I wanted to touch on a little bit more about unstable versus stable chest pain and stable versus unstable cardiac issues. And when we're looking at an arrhythmia, what does that mean? Stability is really going to be a lot based upon the morbidity of the arrhythmia that you're evaluating and the patient condition. So when we're looking at an unstable cardiac change that's reflected in EKG, we're going to see that vital organ function is impaired. And when this organ function is impaired, cardiac arrest is imminent generally. Treatment is required immediately, no delays for these kind of unstable arrhythmias and rhythm changes. Usually there's respiratory failure, profound vital sign changes, including hypotension, which we see a lot of times with shock, ischemic chest pain, acute heart failure, altered level of consciousness or altered mental status. These are some findings that are normal for unstable cardiac changes. For someone that has a stable process that's going on, generally the patient vital organs are stable, and there's time to consider what kind of pharmacologic or diagnostic intervention may be necessary. Usually patients that have stable angina or stable cardiac changes, they may have no symptoms, or they could have some palpitations, lightheadedness, some dyspnea on exertion. So those are some things worth considering when you're thinking about stable versus unstable, because we've talked about that a few times in the previous lectures, but just wanted to provide a little more guidance as far as that's concerned. Thinking about diastole. Diastole is when all of the blood flows into your coronary arteries. So any impairment in diastole can impair the filling of these arteries, resulting in really the earliest signs of myocardial injury, where you have that lack of oxygenation, and then we see that as ST depression on EKG. So when we're thinking about diastole, that's a very important time period when we're looking at the cardiac process of the heartbeat. One thing to consider as far as conduction issues is the importance of the right coronary artery. Your right coronary artery supplies sections of the heart's conduction system, including the AV node and the bundle of His. So if there's an issue with this artery, generally we can see some serious cardiac conduction defects. This can occur as well as an inferior or right ventricular MI with blockage of the RCA's ability to, provide oxygen to that muscle tissue. So when you see a RCA block, it could result in conduction issues because it supplies oxygenation to all of that area. You'll hear terminology of inotropes, chronotropes, and dromotropes. When we're thinking of inotropes, you want to consider its contractility, or its ability to contract that heart muscle tissue. Positive inotropes, such as digitalis and dobutamine, increase that ability of the heart to contract, whereas there's negative inotropes, like beta blockers and calcium channel blockers, that help kind of relax that smooth muscle. So you can start to see some vasodilation with a calcium channel blocker. It decreases that contractility. Chronotropes, this is really affecting heart rhythm rate. That rate, if it's a positive chronotrope, it's increasing the rate, such as adrenaline, versus a negative chronotrope like digoxin, which slows that heart rate down. Dromotropes, this is AV conduction speed. So you have some that are positive dromotropes like phenytoin, which will increase that heart conduction AV speed, and verapamil will slow it down. You might have patients that come in with blocks that need pacing. There's different types of pacers out there. There's transcutaneous pacing, there's implanted temporary pacing, then you go to defibrillators that are implanted for several years at a time. So it's not just medications that may need to be a line of treatment, and drugs may not be the right answer. You can consider like a problem like sinus tachycardia. Sinus tachycardia generally is caused by sympathetic stimulation or hypoxia. The most frequent triggers of, hypoxia or sympathetic stimulation are exercise or pain or fever or anxiety. Not that it couldn't be caused by shock or MI or heart failure, but it doesn't always have to be a severe finding. You have to rule out severe issues. Other causes of sinus tachycardia could be infection, hyperthyroidism, caffeine intake, medications like nicotine or cocaine. So when we're thinking about that tachycardia, what do we want to do about it? We need to treat whatever the underlying cause is to improve that sinus tachycardia. If it is cocaine use, we need to get the patient away from that stimulant and get some therapy for the patient so they're not resulting in going back to that drug dependence. If it's something really as an adverse event like an MI, we need to be able to recognize that and get the patient the right kind of therapy. Putting a patient on a beta blocker because they have sinus tachycardia isn't necessarily the answer. You have to investigate and rule out your differentials. A lot of patients, if they are having worsened cardiac output, they may need pressor infusions or CPR or ACLS for patients that are going into heart failure. So if a patient is being evaluated in a primary care office and you see some abnormal findings on EKG and their case study looks bad, they have poor presenting symptoms, they probably need to go to the ER for further workup and intensive care intervention. When we're thinking about cardioversion versus defibrillation, I put this chart on here because sometimes I think people think it's the same thing, and it's not. These kind of outline some differences between cardioversion and defibrillation, most common differences. I just wanted to touch on some electrolyte issues that are pretty commonly seen with EKG findings. This could be your potassium, magnesium, sodium, and calcium. So we'll just go over those real quick. I'll let you read all this information about hyperkalemia. Generally, hyperkalemia presents with nausea, vomiting, abdominal cramping, weakness. Sometimes they can have numbness to their extremities. With hyperkalemia, when their potassium is too high, you want to think tall, narrow, peaked T waves and shorten QT intervals. When their potassium level gets to 6 or 7 milliequivalents, the P waves will start to flatten out and their QRS widens. And as those QRS waves widen, you start to get worsened arrhythmia issues. With hypokalemia, they present with similar findings of dizziness, muscle cramps, fatigue. Sometimes their blood pressure will drop. They have slowed bowel sounds, irritability, confusion. With these EKG changings for hypokalemia, generally they have a flattened T wave. Sometimes they'll have a depressed ST segment, and then sometimes they'll have QT and PR interval prolongation. So that's something that you can sometimes see. The worse the potassium level gets, lower and lower, can lead to ventricular arrhythmias. I want to say the lowest potassium level I've ever seen was like a 2.3 or something like that. And honestly, her presentation wasn't that bad. She didn't look terrible. With your sodium levels, both hyper and hyponatremia present with EKG changes of sinus tachycardia. So that is something to consider with your sodium balancing issues. When we're thinking about hypocalcemia, having that low calcium level, generally patients will have abdominal cramps, muscle cramps, numbness in their fingers. If you tap on their facial nerves, sometimes they'll have facial twitching. They could have irritability, seizures. Their urine can really slow down to where they're anuric almost. These patients usually have a prolonged QT interval, so it's a long distance between the Q and the T, and it can result in torsade de pointe. Hypercalcemia, having too high of a calcium level. Generally, these patients are thirsty, anorexic. They may have nausea, vomiting, abdominal pain, and bone and flank pain can also be a presenting symptom. These patients can also have low bowel sounds, muscular weakness, confusion, and generally they have lots of urine as opposed to a little bit of urine. EKG changes as opposed to hypocalcemia. Hypercalcemia is going to be shortened QT interval. The arrhythmias and AV blocks can be also pretty common with hypercalcemia. Moving on to the magnesiums, when you have a patient with magnesemia, these patients will have anorexia, sometimes nausea, vomiting, muscle cramps. They may be syncopal, presenting as that as their initial diagnosis, hypotension, seizures, and confusion. EKG changes generally with hypomagnesium. They have a prolonged QT interval. They can have some arrhythmias such as sinus tachycardia or torsade de pointe. So that's something worth thinking about for hypomagnesemia. When their magnesium level is too high, patients can have findings of muscle weakness, fatigue, nausea, vomiting, somnolence, double vision, diplopia, hypotension, facial flushing, confusion. Having a low or too high of a magnesium level can precipitate cardiac arrest. EKG changes, usually we see prolonged PR, QRS, and QT intervals, so that space gets a little bit wider for that QT. And then sometimes we'll see AV block or bradycardia with hypermagnesemia. I have listed here some other clinical pearls that you might consider for patients. If you've worked in critical care, you've probably seen most, if not all, of these issues here listed for other pearls. Hypothermia, this could be, from an exposure like near drowning or prolonged exposure to cold temperatures, but a lot of times, especially in the hospital setting, these could be therapeutic in nature, such as a patient that's status post-cardiac arrest. But you might see these kind of changes with hypothermia, and that may be expected. It may be something worth, notifying to a cardiologist, but if a patient is in the ICU, they're being managed by a critical care provider anyway. Subarachnoid bleed can result as a blunt or penetrating injury to the head. Usually it causes bleeding in that subarachnoid space. Patient has headache, changes in level of consciousness, their neck gets really rigid, nuchal rigidity with a positive Kernig sign. These patients have these kind of findings on EKG, and they can have catecholamines released, resulting in arrhythmia as well. So that can be a pretty significant finding on EKG. Pulmonary embolism, this is usually from obstruction of one or more arteries in the lungs caused by usually like a clot, but it could be from blood or amniotic fluid or air. The EKG listed changes here you could look out for, and that could help differentiate pulmonary embolism from an acute MI, because they are a little bit different. Hypothyroidism, some patients may present with like Hashimoto's, or maybe they had surgical removal of a thyroid gland and haven't had significant enough replacement. These patients might have, hypothermia, hypotension, their sodium level may be low, their blood sugar's low, they may feel lethargic, but these kind of EKG changes are pretty significant for hypothyroidism severe state. When you're treating a patient, you have to rule out your worst differentials, and if you have a lethal arrhythmia, you need to get a patient to a critical care facility as soon as possible. If it's something that's stable, you need to treat the underlying cause. Even if it's something that's critical, the underlying cause needs to be treated, but you have to rule out whether or not this is something that you can treat in a primary care office or it needs to go to the critical care center. I hope you all have learned a few things going through these lectures. If y'all have any questions, you can always email me at stigersa@nsula.edu, and I'll be glad to answer any questions y'all have.